No, sir. I mean, I'm just wait. I'm going to speak for the next
I
one
was
and a half hours. So I'm
I
just
was
preserving my vocal cord strength.
resting your vocal cords. Very good, very good. You guys don't want something on dermatopath? Teach the postgraduates dermatopath? Dermatopath, anybody?
Dr. Nadeem, sir, I think that question is for you.
That no takers here. I tell you, are very bad, yeah.
We are live on YouTube. So all set, should we start?
Yes, sir.
Right, great. Good evening, everybody. Welcome to this evening episode of Pursue, and this is Pursue 13D. And this is the pathology of head and neck, and we are streaming live from AIIMS New Delhi via Kolkata. A very interesting topic, salivary gland neoplasm, expect the unexpected. To talk on that, we have Dr. Aanchal Kakkar, who's an MD from AIIMS New Delhi. Presently, she's an assistant professor in the Department of Pathology, AIIMS New Delhi. Earlier, she was as an assistant professor in the Department of Pathology at Tata Memorial Hospital, Mumbai. Her area of interest is head and neck pathology, pediatric pathology, and she's got more than 125 publications in international and national journals, including citations in WHO fascicles, 10 book chapters. She's also a contributor into the famous Robbins and Cothran's pathologic basis of disease, with multiple awards, including the Dr. N.C. Nayak Award for the most talented young pathologist by IAPM Delhi. Indeed, she's a very talented person. So before I ask her to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Aanchal Kakkar, ma'am, please share your screen and let's start. Thank you.
Good evening, sir. Thank you once again for inviting me to the Pursue series. And I'll be talking on salivary gland neoplasms today. Expect the unexpected. And salivary gland neoplasms are a very heterogeneous group of tumors. And we really don't know what to expect when we see especially an aspirate or a coronal biopsy from the parotid gland, more commonly as compared to the other salivary glands. So I'm just going to jump right in. Most of the time, what we can do is just take a deep breath and just dive off a cliff. So let's just go on to the first case here. So the first case is of a 48-year-old male with a parotid swelling. You can see here that this is an aspirate. This is the path and the gene sustain slides. And here you can see nice three-dimensional fragments which have papillary architecture, some trabecular architecture as well. And in the background you can see some bare nuclei. On higher magnification, you can see that these tumor cells have scant cytoplasm and they have enlarged nuclei which have considerable pleomorphism. Some vacuolation of cytoplasm is evident here, whereas most of the cells are devoid of cytoplasm. They have scant cytoplasm. Now, what is important is when you're looking at the parotid, what do you look for when you're looking at something that looks like a high-grade malignancy? The possibilities you would think of are a sebaceous, a salivary duct carcinoma, a high-grade muco-epidermoid carcinoma, which are the two most common high-grade tumors you would expect. So in this aspect, what you see is that there is no mucin, there is no evidence of squamous cells, which you would look for in a muco-epidermoid carcinoma. There is no necrosis, which you would see in a high-grade carcinoma, particularly a salivary duct carcinoma. And also salivary duct carcinoma, the cells have abundant cytoplasm, which you're not seeing here. So this aspirate was reported as a poorly differentiated carcinoma. Let's go on and see the histology. The patient underwent a parotidectomy, and here you can see the normal salivary gland, and here is a tumor which has pushing borders, but in some areas you can see that it's more infiltrated in the salivary gland. There are large lobules of tumor cells with central comedonecrosis. At this magnification, the tumor appears a bit blue looking. Here what you can see are multiple foci of perineural infiltration where the tumor is encasing the nerves in the parotid. This is the high magnification. Very evident here are multiple mitotic figures. You can see that the tumor cells, they appear to have abundant cytoplasm, which is pale eosinophilic, and they have vesicular nuclei. Sort of trabecular architecture is evident within these solid areas, but there are no nucleoli, and the cytoplasm is quite pale and not apocrine appearing, which you would expect in a salivary duct carcinoma. You're seeing only one cell type, so no multiple cell types, no mucus cells, no intermediate cells. This is a higher magnification, and you can see that some of these cells, they have some cytoplasmic vacuolation, which is better appreciated here. You can see that these vacuoles are indenting the nucleus of the cells. And this is a feature of sebaceous carcinoma. So we performed immunohistochemistry for androgen receptor, and this is positive, and this was called as a sebaceous carcinoma. Now we do get sebaceous adenocarcinomas in the salivary gland as well, but we went back and looked at the patient and we looked for the previous history, and we found that this patient had undergone surgery for an eyelid tumor 5 years prior. So this was, which was called a sebaceous carcinoma. So this was a sebaceous carcinoma which is from the eyelid, which is metastatic to the parotid. So with this diagnosis, we went back to our cytology to take a look at if we could identify some of these features. And here we could see that some of the cells did show cytoplasmic vacuolation. While there were large vacuoles in some of the cells, the others showed very fine cytoplasmic multivacuolation, which is characteristic of this tumor, which was appreciable on cytology as well. And this is the PAP showing the same thing, where you can see cytoplasmic vacuoles. So sebaceous carcinoma most commonly arises from the head and neck, skin in the head and neck, particularly in a periocular location, such as the eyelids. It is the most common eyelid malignancy after basal cell carcinoma. After basal cell carcinoma, it is most commonly seen in the upper eyelid, where it is 2 to 3 times more frequent as compared to the lower lid, and then it is followed by the caruncle and the eyebrow. It's most commonly seen in middle-aged women, and it is believed to arise from the meibomian glands. As you can see here, this is the eyelid, and this is the conjunctiva, and this is a large tumor with central area of comedonecrosis. It can also arise from the glands of Zeiss and sebaceous glands, and often there is complete replacement of the tarsus, so you can't really identify where it's arising from. Sebaceous carcinoma is characterized by the presence of sebocytic differentiation, which shows abundant multivesicular cytoplasm and nuclear scalloping, which is seen here. And however, more frequently, sebocytic differentiation is not evident, and you just see irregular lobular masses of tumor cells with central comedonecrosis. This is because the tumor may be well to poorly differentiated. In well-differentiated tumors, there's abundant cytoplasm in the tumor cells, vesicular nuclei, distinct nucleoli, and on fat stains of frozen sections of fixed tissue also, you can demonstrate that many of the cells contain lipid. However, in poorly differentiated tumors, they have a high NC ratio, prominent nucleoli, and amphiphilic to basophilic cytoplasm with squared off nuclei, which is because of the nuclei abutting each other closely. According to WHO, they can be graded as grade 1, 2, and 3 based on the architecture, whether they have well demarcated equal size lobules, well defined nests with infiltrative profiles or confluent cell groups in grade 2, and grade 3 has sheet like invasive growth. Sebaceous carcinoma frequently shows intraepithelial spread, most commonly seen in the eyelid, followed by the conjunctiva, and rarely into the cornea as well. You can also see pagetoid change, where tumor cells invade the epidermis or into the cornea and conjunctiva, where they produce a change resembling Paget disease. Sebaceous carcinoma has also been referred to as the great masquerader. Not only melanoma has this name, as there are a number of morphological variations, including basaloid, variant squamoid, appearance, sarcomatoid subtype, seboapocrine carcinoma, and also a pseudo-neuroendocrine ripple pattern has been described. Immunohistochemistry shows that these tumor cells are immunopositive for cytokeratin, epithelial membrane antigen, which highlights the vacuoles, and P40 and P63. Apart from that, they are diffusely positive for androgen receptor, adipofillin, which again highlights the cytoplasmic vacuoles, and factor 13A, and these are the ones which help to differentiate from salivary gland tumors, squamous cell carcinoma, and basal cell carcinoma. These tumors have a high risk of local recurrence and metastasis. Coming to metastasis to the parotid. The parotid gland houses around 15 to 20 intra and periparotid lymph nodes, as it is the last salivary gland to get encapsulated during embryonal development. Due to this late encapsulation, there is entrapment of lymphoid tissue within the gland, as well as entrapment of parotid ducts and acini within the periparotid lymph nodes. It serves as the first echelon node, which drains the skin over the root of the nose, the eyelids, the frontotemporal scalp. In the eye, it drains the conjunctiva and the lacrimal gland. In the anterior part of the ear, it drains the external auditory canal. It also drains the tympanic membrane and the tympanic cavity. Next, it drains the posterior part and floor of the nasal cavity, part of the palate, and the nasopharynx. So, any malignancy arising here can metastasize to the intraparotid lymph nodes. Lymph nodes are intimately associated with the salivary tissue in the parotid, and also, as I mentioned, they contain benign salivary inclusions beneath the capsule. So, a primary salivary gland neoplasm can quite easily extend into these lymph nodes and even arise from these salivary inclusions. The parotid is involved by metastasis more than 20 times more often than other major salivary glands due to this, and metastases have been found to account for about 10 to 75% of all parotid malignancies in various series. It is as high as 75% in countries where there is intense sun exposure and the incidence of cutaneous squamous cell carcinoma is very high, such as Australia. And here, cutaneous squamous cell carcinoma and melanoma are the most frequent primaries to metastasize to the parotid. However, in our setup, we've seen that eyelid tumors and intraorbital tumors are the ones which most frequently metastasize to the parotid. Interestingly, distant primaries can also metastasize to the parotid, and there are reports of lung, kidney, breast, and prostate cancers metastasizing here. And the parotid mass may be the first manifestation of disease in such patients. Also, particularly in melanomas and intraclavicular primaries. How do we make a diagnosis of metastasis to parotid? Ideally, you should have the history of a non-salivary gland primary cancer, but in our setting, most of the time we have patients who don't come with the history. Next, if you see morphology, which is not typical of a primary salivary gland neoplasm, it should ring a bell and make you stop and think of something else. Metastases usually have high-grade features, and perineural invasion, as I showed in this case, is usually prominent. Based on identification of characteristic features of the primary, that would be perfect if you could make the diagnosis when you don't have the history at all. Also, you need to use ancillary techniques which would help to distinguish from primary salivary gland tumors. Metastases are usually high-grade malignancies, and they grow quickly, and they can quickly efface and involve intraparotid lymph node. So the absence of intraparotid nodal involvement does not rule out the possibility of a metastasis if you're seeing the tumor purely in an intraparenchymal location. Next, we come to case 2, which is of a 53-year-old male with a parotid mass. FNAC was performed, which showed cohesive clusters of tumor cells with cytoplasmic vacuolation in some of the cells. And in addition, there were squamous cells, as you can see here. They're large polygonal cells which show some orangophilic cytoplasm. They have large vesicular nuclei with prominent nucleoli. In this fragment, you can see that there is marked anisonucleosis of the tumor cells. And here you can see some fragments of desmoplastic stroma. Now, based on the location in the parotid, the first possibility that was given with a high-grade carcinoma showing the presence of squamous cells was high-grade Muco-Epidermoid carcinoma, and the second possibility was squamous cell carcinoma. No mucin was present and no mucus or intermediate cells were identified, so this needs to be kept in mind. The patient underwent a parotidectomy, and here you can see in the salivary gland you have a keratinizing squamous cell carcinoma, and there's extensive desmoplasia, and as I said, perineural invasion is very frequent. So this is called a squamous cell carcinoma, and it was advised to exclude metastasis before thinking of a primary. To definitively call something a primary squamous cell carcinoma of the parotid, you need to identify the tumor within the dilated duct along with dysplasia or in the lining of the ductal epithelial cells. Only then, and you should have the history of long-standing silolithiasis, which is the precursor lesion for squamous cell carcinoma. In the absence of this, it would be best advised to call it a squamous cell carcinoma and ask the clinician to exclude a metastasis. So with this, the patient was worked up extensively, and a biopsy from the supraglottis showed the presence of a well-differentiated squamous cell carcinoma. Next case is that of a 77-year-old male who had a parotid swelling, and again here this aspirate shows you cohesive groups of tumor cells along with abundant singly dispersed cells in the background. You can see that the cells have markedly atypical nuclei with hyperchromasia, scant cytoplasm, and there are a lot of keratinized cells in the background, which are more evident here. You can see the keratinized cytoplasm, which is orangophilic, and ink blot nuclei, which are typical of squamous cell carcinoma. There's also necrosis, inflammation, and on GeneSA you can appreciate the slate gray or robin blue cytoplasm of the keratinized cells. So this was a squamous cell carcinoma. The patient was worked up and he was found to have a primary in the nasopharynx. So in the parotid glands, squamous cell carcinoma most commonly represents a metastasis or direct extension from a cutaneous primary, whereas in the submandibular gland, the squamous cell carcinoma is most likely a metastasis from a mucosal head and neck primary. De novo squamous cell carcinoma needs to have history consistent with long-standing silolithiasis in order to make the diagnosis. How do you differentiate from high-grade Muco-Epidermoid carcinoma, which is the first diagnosis you would think of? High-grade Muco-Epidermoid carcinoma typically would contain foci of low or intermediate grade Muco-Epidermoid carcinoma. You should see some mucus cells, intermediate cells, and some mucin in the background, which was not identified in either of these cases. On immunohistochemistry in a biopsy or on a dissection, you would see diffuse cytokeratin CK7 positivity, whereas P40 would be positive only in the intermediate and epidermoid cells, in the epidermoid cells, and also you could stain for MUC1, MUC4, MUC5AC, which predominantly stain the mucus cells. No overt keratinization or keratin pearls are seen in high-grade Muco-Epidermoid carcinoma. So if you see this, you really should reconsider your diagnosis, which is exactly what is mentioned in the WHO. Metastatic squamous cell carcinoma, on the other hand, shows keratinized squamous cells and abundant squamous pearls may be present. The nuclear atypia is much more marked as compared to high-grade Muco-Epidermoid carcinoma. Immunohistochemically, you would see a single cell population which is diffusely P40 and CK56 positive. Again, as I mentioned, you would see a lot of perineural invasion in a metastatic squamous cell carcinoma. Next case is of a 65-year-old female with an aspirate from the parotid. On low magnification, you can see that there are cohesive clusters of cells as well as dispersed cells in the background. And let's go to higher magnification, and you can see that the tumor cells are round to ovoid to spindle shaped, and there are a lot of cells which contain black pigment in their cytoplasm. Here on GeneSA, you can see that the cells have scant cytoplasm and there's considerable anisonucleosis, which is also appreciable here. You have binucleation and pigment granules within the cytoplasm again. Here you can see the nice anisonucleosis that is present. Nucleoli are not readily appreciable except for in couple of cells only. So this was a case of malignant melanoma. The patient had a temporoparietal scalp lesion. This is the epidermis, and this is the cutaneous melanoma that you can see. On high magnification, the tumor cells are polygonal to spindle shaped and they contain abundant pigment. So the parotidectomy also showed similar features. Metastasis from melanoma in the parotid can be from a primary cutaneous melanoma, and in Western literature, it is the second most common primary to metastasize to the parotid. Apart from cutaneous melanoma, conjunctival and uveal melanoma and head and neck mucosal melanomas can also metastasize to the parotid, and the latter are frequently amelanotic or spindle cell melanoma, which would make the diagnosis very difficult if you didn't have the history. On FNAC, how would you make the diagnosis? You see discohesive pleomorphic cells which have an admixed population of polygonal to spindle-shaped cells. Some of them have eccentric nuclei. Prominent macronucleoli would help you, intranuclear inclusions, and of course, if you saw the black pigment within the cytoplasm. Case 5 is of a 75-year-old male with a parotid mass. So here you can see this is the parotid, and we have an infiltrative tumor with cribriform architecture. Here you can see that this area has cribriform architecture, whereas this area is a little more solid appearing with smaller punched out, smaller spaces. This is a solid area, and here you can see a trabecular pattern with scant mucin in the intervening areas. This solid area again has some extracellular mucin, and again these cribriform areas are evident here. So on this magnification, the possibilities I would consider would be a solid adenoid-cystic carcinoma because it has solid and cribriform appearance, or I would also consider a basal cell adenocarcinoma. However, the mucin doesn't quite fit in with either of those. If you look at these cribriform areas, they don't have punched out margins, which you expect to see in an adenoid-cystic carcinoma. These are not punched out spaces. Here you can see that the nuclei are quite spaced out, indicating that the cells have considerable amount of cytoplasm and they look quite uniform. The nuclei don't look as hyperchromatic as you would expect in an adenoid cystic carcinoma. It looks a bit off for an adenoid cystic. The higher magnification shows that the cells are very uniform with fine powdery chromatin and pale eosinophilic cytoplasm to clear cytoplasm. Some rosette-like structures are also present here. And again, this doesn't quite fit. This tumor was infiltrating into the adjacent skeletal muscle, and you can see extensive perineural invasion was also present. So with the possibilities of basal cell adenocarcinoma and an adenoid cystic carcinoma, we performed immunohistochemistry. CD117 is negative. This is P40, which is negative, except at the periphery of some of these dilated spaces, you can see that P40 positive cells are present. This is SOX10, which was again negative, so adenoid cystic carcinoma is out. This is an entrapped nerve, which is SOX10 positive. Beta catenin was performed, although only a very small portion of basal cell adenocarcinomas are positive for beta catenin. The more frequent positivity is seen in basal cell adenomas. Anyway, we performed it and it is negative. Smooth muscle actin was also performed and that was negative because you expect a mixed abluminal-luminal phenotype in both of these tumors, but we didn't get any of the myoepithelial markers being positive, both SMA and P40. CK7 shows positivity in some of the cells, and this is CK56. Again, we're seeing that there's positivity at the periphery of some of these smaller solid areas. So based on the histological features, I thought of a diagnosis and I went ahead and did the immunohistochemistry, and it was positive for synaptophysin and chromogranin, and also for estrogen receptor, progesterone receptor, and androgen receptor. Mammoglobin and GCDF-P15 are also positive. The Ki67 labeling index is low. So with these features, the diagnosis is of a metastatic endocrine mucin-producing sweat gland carcinoma. We went back and looked at the patient's history. She had an eyelid tumor in 2012, which was diagnosed as a poorly differentiated carcinoma. We reviewed the slides from our ophthalmic pathology division, and they had the identical morphology to this tumor. The tree of FNAC was also available, and incidentally, I had reported it, and I had described it as a carcinoma with focal papillary and acinar architecture. The cells had moderate amount of granular cytoplasm round to ovoid uniform nuclei, and some of the cells had eccentrically placed nuclei, giving a myoepithelial appearance. So I call it a malignant neoplasm with possibilities of secretory carcinoma and myoepithelial carcinoma being considered. And that's a little weird because they're just not differential diagnosis of each other. But it had such varied morphology with the papillary and acinar architecture and the myoepithelial appearing cells. So 2 weeks after this FNAC was reported, the ENT resident came back and said that this patient had an eyelid tumor. Do you think that this could be a metastatic adenocarcinoma from the eyelid? And I said that yes, of course it could be. And they did not provide the history to us earlier because they wanted to see what diagnosis we would make without the history. So this happens very frequently, I guess, and that is why you always need to think of metastasis whenever, even if you don't have the history, whenever you see something which doesn't classically resemble a primary salivary gland tumor. So what is endocrine mucin producing sweat gland carcinoma? It is a fairly recently described low-grade sweat gland carcinoma with neuroendocrine differentiation and a predilection for the eyelids. It is a postulated precursor of cutaneous mucinous carcinoma, and it is considered the cutaneous analog of solid papillary breast carcinoma, and it has similar features with the uniform cells with neuroendocrine appearance as solid papillary breast carcinoma. It occurs in older patients and is more frequent twice as more frequent in females as compared to males. On histopathology, you see expansile nodules as we saw with papillary, solid, cystic and cribriform growth, and it's composed of small to medium-sized cells which are oval to polygonal in shape with lightly eosinophilic to bluish cytoplasm. It has bland nuclei, mitotic activity is present but not brisk, and intracytoplasmic intracellular mucin may be present. When you see large pools of mucin with tumor cells floating within them and infiltrative glands, that would indicate progression to mucinous carcinoma. On immunohistochemistry, they classically display neuroendocrine markers and also estrogen receptor, progesterone receptor, GCDF15 and mammoglobin, which again is akin to the breast carcinoma. In situ carcinoma has been described within the eccrine ducts in the skin, when the tumor is in the skin, with an intact myoepithelial cell layer which is highlighted by P40, P63 and CK56. Now this was also seen in our tumor, but this was a metastasis. So why did we see this? So it's possible that the tumor metastasized to the intraparotid lymph nodes, and then once it spread over into the parenchyma, it entered the ducts and grew within the ducts of the salivary gland and expanded them, and ultimately you have a residual layer of basal cells around the expanded ducts. The larger expansile nodules in this tumor usually lack a myoepithelial layer, and it may be WT1 positive as it is of eccrine origin. So there are 2 reports in literature of this tumor having metastasized, and interestingly both of them have metastasized to the parotid. The first one, which was reported last year, was of a 71-year-old female. She had an eyelid tumor 10 years prior, and which was initially diagnosed as a papillary epithelial proliferation, possibly a papilloma, but clinically it was a non-melanoma skin cancer, and the metastasis which occurred 10 years later were to the intraparotid node. On FNAC, this metastatic tumor showed bland hypercellular plasmacytoid cells with round nuclei, small nucleoli, and delicate wispy cytoplasm. So these plasmacytoid cells that they describe actually resemble what I saw and call the cells with eccentric nuclei in my aspirate. And the next case has just been published maybe 2 weeks ago, and this is also one which has metastasized to the parotid and to the ribs. So this was an eyelid tumor in a 66-year-old male, so you can see that the age group in all 3 cases is similar. It was initially diagnosed as a hyperadenoma with atypia, and there were multiple local recurrences before the metastasis occurred to parotid after a long duration. And on FNAC, it was reported as an acinic cell carcinoma, again highlighting the uniformity of the cells and the low-grade appearance that you're likely to see on FNA. We'll go on to the next case, which is of a 41-year-old male who was a known case of a sinonasal tumor. This is an easy one. You can see that this is a small round cell tumor. On higher magnification, you can see that some of the cells you can appreciate stipple chromatid, and here you can see some rosette-like structures. So with a sinonasal tumor, the history of a sinonasal tumor, small round cells with rosettes, the diagnosis was of a metastatic olfactory neuroblastoma. This is the intraparotid lymph node, which later showed similar tumor cells with a lot of fibrosis, as this patient had received neoadjuvant chemotherapy, and so we used immunohistochemistry. This is synaptophysin, which highlighted the tumor cells. So in olfactory neuroblastoma, nodal metastasis can be seen at presentation in 5 to 8% of patients, and subsequent recurrence in neck nodes is seen in 20 to 25% of patients. And lymph node metastasis is an important prognostic factor for 5-year survival, with 29% survival with nodal metastasis as compared to 64% without nodal metastasis. In our institute, we have looked for occult lymph node metastasis in upfront neck dissections in olfactory neuroblastoma patients, which has not been evaluated previously, and we found 25% of cases showed occult lymph node metastasis, and the size of this metastasis was very small in all the cases in which it was identified, less than 2 millimeters, and it did not show uptake on technetium-99 sulfur colloid scan. So it is possible that the frequency of metastasis in olfactory neuroblastoma is actually much higher than what we know of. The next case is of a 9-year-old male child with a slowly progressive painless swelling in the right preauricular region for 1 month. On contrast enhanced MRI, there's an enhancing intraparotid mass along with a necrotic right cervical lymph node here, and both of which also showed uptake in the FDG PET CT. So we initially got there was a core biopsy from this tumor, and here you can see this is the normal parotid and this is the tumor tissue, which looks like a small round blue cell tumor, but here there are some glandular structures better appreciated here. It looks like there's some sort of cribriform pattern. On higher magnification, these cells appear basaloid. There is some tubule formation going on here. And here the tumor cells are arranged in cords and tubules in a loose myxoid to edematous matrix. On higher magnification, they are indeed small round blue cells, and at places they are embedded, they appear to have some sort of fibrillary cytoplasm with a syncytium sort of appearance. And in other areas, they look like they have an epithelial appearance here with stratification of nuclei and a sort of papillary fragments being formed. And here you can see that some tubules are present which have multi-layering of the nuclei. In the pediatric age group, parotid swellings are mostly due to benign conditions, and the most frequent primary malignancies seen in children are Muco-Epidermoid carcinoma, followed by actinic cell carcinoma and Adnocistic carcinoma. Whereas in infants, Cilioblastoma is the most frequently encountered tumor. In the current case, the possibilities that were considered were Adnocistic carcinoma, Cilioblastoma, and other tumors that you always think of in children, like a germ cell tumor, Ewing sarcoma, neuroblastoma, and other poorly differentiated malignant tumors like rhabdomyosarcoma and desmoplastic small round cell tumor. So before I saw this case, immunohistochemistry had been performed, and this is cytokeratin, which was positive in the epithelial appearing areas, whereas the round cell appearing areas were negative. Epithelial membrane antigen was focally positive. CD117, which you expect to see in an adenocarcinoma carcinoma, in the luminal cells, was negative. SAL4 was negative, excluding a germ cell tumor. Synaptophysin and chromogranin, which were performed, were positive. However, the tumor was also positive for desmin. Myogenin was negative. MYC2 or CD99 was positive, although not really showing good membranous positivity. It was more of a cytoplasmic positivity. WT1 was also positive. It was performed to exclude a desmoplastic small round cell tumor. INI1 expression was retained, and the Ki67 labeling index was fairly high. So when you perform a wide immunohistochemical panel and it doesn't give you any it doesn't take you in any proper direction at the end of it, what you have to do is you have to go back to morphology, and that's exactly what we did. This patient also had an FNAC, and this is what we reviewed at that point. And this FNAC has classical features of this tumor. If you've seen it once, you're not going to forget it. And so this is a small round blue cell tumor. There are some rosettes. There are groups of cells which are embedded in this fibrillary matrix, just like we saw on the biopsy. These rosettes are showing multilayering, which is akin to epithelial tubules, which is also seen here. And when I saw this, I had one thought in mind, and so we called the patient back and we asked for the history. And sure enough, this patient had undergone an enucleation 3 years prior for a tumor which was arising from the ciliary body, which was adherent to the posterior surface of the cornea, and was diagnosed as an ocular medulloepithelioma. And he had undergone an orbital exentration following that for the residual tumor. And this is the clinical information that the parroted biopsy came with. Just preauricular swelling since 1 month and nothing about the previous surgery. So this is what happens a lot of times, and you really have to extend yourself to come to a diagnosis, if especially when it's a metastatic tumor. So this is the parrotectomy that was performed, and here you can see this is a salivary gland. This is an intraparotid lymph node with residual follicles and a tumor within it. This is a cervical lymph node, which again shows similar tumor. And the tumor showed, similar to the biopsy, these multi-layered epithelial tubules and rosettes. And the tumor cells are small round blue cells, which are seen in trabecular appearance and as well as lining these epithelial tubules and rosettes. In some areas, like the biopsy, we saw, like the aspirate, we saw that these cells were embedded in a fibrillary matrix. And interestingly, we found some areas of cartilage as well. So, ocular melanoma is an neuroepithelial tumor that arises from the non-pigmented ciliary epithelium. It's the second most common primary intraocular malignancy in the first decade of life, and it's associated with germline mutations in the DICER gene. The characteristic histopathological features are cord sheets and sheets of primitive neuroepithelial cells, which are surrounded by a hypocellular loose myxoid matrix. Rosettes are seen, which are usually larger and more cellular than flexner intestino rosettes. You can also see homoerite rosettes. Characteristically, you see neuroepithelial tubules, which is what we saw in our case, which have an internal and external limiting membrane, which may be glial, cartilage like we saw in our case, or rhabdomyoblast. And this is seen in 1/3 of cases. On FNAC, you see a small round cell tumor with loose fibrillary background and epithelial-like structures, which are actually the epithelial tubules, which have multi-layered oval to columnar cells with hyperchromatic nuclei. And this is the case which I had seen about 10 years back, and it is something that I recall till today, which is how I made the diagnosis. Metastasis from ocular medulloepithelioma are rare, but they have been described to preauricular submandibular lymph nodes, and this was also a case which metastasized to the preauricular lymph node. Case 8 is of a 38-year-old male with the parroted mass, and again a core biopsy is done from the mass. You can see this is a cellular tumor, and there are areas of necrosis here, again appreciable on high magnification as well. These are the tumor cells with large areas of necrosis, and the tumor cells are quite polygonal in shape with hyperchromatic nuclei bonded to abundant amount of eosinophilic cytoplasm. They look quite cohesive in this area, whereas in other areas they are more syncytial-like. And this is the high magnification. Here you can see that they have fairly well-defined cytoplasmic borders and have an epithelial appearance, whereas here they are more spindled and forming a syncytium. And another number of tumor giant cells, nuclear hyperplasia, very brisk minority. And here this looks like a blood vessel with tumor cells within it. And this came with the history of a brain tumor, one in, I think, 6 months prior. So this is GFAP, which is intensely positive. IAPM was performed IDH negative, ATRX retained, P53 wild type, and this is the Ki67 Kipling index. So, sorry, this was 1.5 years prior that the patient had been operated for a glioblastoma, and here you can see a cellular tumor with large areas of necrosis, and the similar kind of tumor cells are seen as we saw in the biopsy. So, extraneural metastases of glioblastoma are extremely uncommon. They're limited to case reports, and in some series, they have been found to have an incidence ranging from 0.2 to 2%, and metastases outside of the CNS are associated with significantly shorter survival. Metastatic disease can occur through hematogenous, lymphatic, or CSF spread, and around 10 cases of GBM metastasis to the parotid gland have been reported so far. How does glioblastoma metastasize outside of the CNS when it is protected by the blood-brain barrier? So, surgery and radiation therapy lead to iatrogenic disruption of the blood-brain barrier, making it easier for the tumor cells to spread outside. Also, peripheral circulating tumor cells have been identified in GBM patients, indicating that they can spread through a hematogenous route. However, as these metastasis of glioblastomas is extremely rare, you should always exclude a second primary by doing a histological or cytological examination if there is another mass in a patient with a primary glioblastoma. Case 9 is of a 68-year-old male with a parotid mass. An FNA was done, and here we can see cohesive clusters of tumor cells in the PAP and GIMSA. And here you can see there are some residual salivary gland. You can see the acini with a grape-like appearance, and these are the tumor fragments which are seen in sheets and in pseudopapillary architecture, as well as some three-dimensional balls and irregular cohesive clusters. On higher magnification, you can see that these cells have large vesicular nuclei, abundant cytoplasm. Some of the cells have prominent nucleoli. There are a lot of interspersed neutrophils along with the tumor. And here you can see some sort of acinar architecture. Now, if I was looking at this, I would probably think of a salivary duct carcinoma and call it that. Here you can see again that these sheets of tumor cells have very considerable nuclear pleomorphism, prominent nucleoli in these large vesicular nuclei, and here you can see there is considerable anisonucleosis. Again, you can see a lot of neutrophils are infiltrating into this tumor. However, frank necrosis was not identified. Now, this was reported as a poorly differentiated carcinoma with evidence of ductal differentiation, and subsequently 6 months later the patient was found to have a lung mass, and a coronal biopsy was obtained from the lung mass, and the oncologist asked us that is this a metastasis or is it a second primary in the lung. And here you can see the coronal biopsy shows you glandular as well as some micropapillary architecture. This is a higher magnification showing the same. And again, you can see here that there is neutrophilic infiltrate among the tumor cells like we saw in the aspirate. This is the higher magnification of the same. Glandular architecture, small micropapillary structures are present. This was CK7 positive, CK20 negative, TTF positive, and napsin positive. Sorry, this was a poor biopsy from the parotid when the patient developed a lung mass and they wanted to exclude a metastasis. So this was a lung carcinoma metastatic to the parotid. Lung malignancies most commonly metastasize to mediastinal and supraclavicular lymph nodes, and distant metastases occur to the liver, bone, adrenals, and brain. Metastasis from lung carcinoma to the parotid is a rare event, but it has been described for squamous cell carcinoma, adenocarcinoma, as well as small cell carcinoma. In majority of the cases, there is a known history of a salivary gland primary. However, in some cases, the history is not available, or the primary tumor is not identified. The differential diagnosis, when you think of primary salivary gland tumors would be a salivary duct carcinoma, polymorphous adenocarcinoma, adenocarcinoma NOS, Muco-Epidermoid carcinoma, or neuroendocrine carcinoma based on the morphology. However, in all of these primary salivary gland tumors, you would not see admixed normal salivary acini and ductal epithelial cells, which are seen in metastasis. This is an interesting article. Secondary malignant tumors of the parotid gland are not a secondary problem. So in this study, which was one of the largest series of metastasis to the parotid, they had 66 patients, which they identified over a 50-year period, which is considerably long. We have about 50 samples from 42 patients over 10 years, and they found that metastasis to the parotid from tumors below the clavicle constituted 10 to 20% of all metastasis to parotid, and they included lung carcinoma, breast carcinoma, kidney tumors, pancreatic and luminal GIT carcinomas. And they found that there was considerable concordance between FNAC and final histopath diagnosis of 71%. However, it was high for squamous cell carcinoma and low for melanoma, but they did not comment on the concordance between FNAC and histopath diagnosis for these adenocarcinomas. Case 10 is of a 22-year-old male. On MRI, there was a 5 into 4 into 2 centimeter lesion in the right parotid. He underwent an excision biopsy, and his slides and tissue blocks were submitted to us for review. So here you can see the parotid parenchyma, and majority of the parotid has been replaced by a tumor which has large lobules separated by some fibrous bands. It has a variably myxoid to collagenous stroma in which tumor cells appear to be embedded. On higher magnification, there's solid architecture, small irregular nests of tumor cells, as well as infiltrating cords of tumor cells. Here you can appreciate these in the solid areas, the fibrous bands which are dividing the tumor cells into lobules, and here you can see what looks like peripheral palisading of the tumor cells, which appear quite blue looking with scant cytoplasm. And on higher magnification, you can see that the nuclei of these of the tumor cells are fairly monotonous. They have clear two pale eosinophilic cytoplasm. The chromatin is fine, nucleoli are not conspicuous, and mitotic activity is inconspicuous as well. At places, there were perivascular rosettes, which are formed by the tumor cells, and interestingly, there are small foci of squamous differentiation and keratinization, forming keratin pearls. So with these features, my first diagnostic consideration would be a nut carcinoma, which has been described in the parotid. We also found foci of bone formation and calcification within the tumor, which was an interesting finding. So we went ahead and did IHC, and of course you would think of a primary salivary gland tumor, it would be with this sort of architecture of small cells with scant cytoplasm. You would think of an adenocistic carcinoma probably. So we performed immunohistochemistry. CD117 is diffusely positive. In an adenocistic carcinoma, you expect positivity more in the luminal cells and not in the abluminal cells, but here it is diffusely positive. CK7 was negative in the tumor cells and highlights a few entrapped residual ducts, and P40 is again diffusely positive, while smooth muscle actin is negative, and this doesn't fit in with the profile of biphasic cellular population in an adenocistic carcinoma. And NUT immunohistochemistry was also negative. This is the Ki67. So where do we go now with basaloid appearing tumor with keratin pearls and squamous differentiation? I think Dr. Munita has recently shown a case, and all of you should be able to pick up the diagnosis. This is CD99 showing membranous positivity, and NKX2 2.2 is positive, diffusely positive in the tumor cells. Synaptophysin shows variable positivity in clusters as well as isolated single cells being positive. So this was a case of parotid adenocarcinoma like Ewing sarcoma. This is a rare adamantinoma-like variant of Ewing sarcoma which exhibits evidence of squamoid differentiation on the morphological, immunohistochemical, and ultrastructural level in the form of squamous pearls and keratinization, diffuse immunopositivity for high molecular weight cytokeratins P63 and P40, and the presence of desmosomes and tonofilaments. Similar to Ewing sarcoma, classical Ewing sarcoma, it harbors the T1122 rearrangement with an EWSR1 Fly1 fusion. Until recently, it was only described in bone and soft tissue of extremities. However, it has now been reported in various sites in the head and neck, including the sinonasal region, the thyroid, the orbit, and around 10 cases have been reported in the parotid and 2 in the submandibular gland. This tumor has a wide age range, and the morphology is of sheaths, nests, and lobules of basaloid cells with a variably myxoid, fibromyxoid, or hyalinized stroma. There is presence of basement membrane material between the tumor cells, as seen here. Peripheral palisading of the tumor cells, where the nuclei are arranged perpendicular to the fibrocollagenous septae, and squamous differentiation in the form of intercellular bridges, keratinization, and abrupt small keratin pearls. These last few features of squamous differentiation have been described to be less common in the salivary gland as compared to other sites. However, the number of cases reported is quite small, so maybe we'll get to know a little better in the future. What is important is that this tumor, unlike the differential diagnosis that you would consider, has strikingly isomorphic nuclei which are round over, and that should help you to pick it up. On immunohistochemistry, epithelial markers like cytokeratin and markers of squamous differentiation like P40 and P63 are diffusely positive, apart from CD99 and KX2.2, which are positive in all Ewing sarcomas, and synaptophysin shows variable positivity in the tumor cells. So what are the clues to adamantinoma like Ewing sarcoma? Cytologic monotony despite high-grade features like necrosis and frequent mitosis is what is described. However, in our tumor, we did not see necrosis and mitotic activity was infrequent. We had received only one block, so we can't be sure that the rest of the tumor did not show necrosis and increased mitosis. Next is the presence of abrupt small keratin pearls, rosettes, and peripheral palisading when present should help you to think of this diagnosis. Lastly, on immunohistochemistry, when you see diffuse strong P40 staining coupled with synaptophysin positivity should also make you think of this tumor. In the salivary gland, what is the differential diagnosis? All tumors with a basaloid or myoepithelial phenotype would make you think, would come into the differential diagnosis. Firstly, adenocistic carcinoma solid type. And although it's solid, focal cribriform architecture is usually seen in the solid type as well. It has a biphasic cell population, biphasic P40 expression, not diffuse, and also you can use MIB immunohistochemistry or demonstrate a MIB or MIB-L1 rearrangement. Next is basal cell adenocarcinoma, which is usually low grade in appearance, which would enter the differential diagnosis in our case, and it does not show necrosis or brisk mitosis. However, again, it is a biphasic tumor with luminal and abluminal differentiation. Majority of cases do show cyclin D1 positivity, which would help in differentiating. Myoepithelial carcinomas can be high grade and can resemble adamantinoma like Ewing sarcoma. However, immunohistochemistry for myoepithelial markers like smooth muscle actin and calpunin would be negative, while P40 and P63 would be common to both tumors. Nut carcinoma, again, you have immunohistochemistry for nut, which would help you to differentiate between the two. In the head and neck, adamantinoma like Ewing sarcoma has been found to have outcomes following surgery and therapizes. Is it truly an Ewing sarcoma, or is it a different tumor which just harbors the same fusion? And however, for now, the terminology remains the same, with it being considered a histological subtype of Ewing sarcoma. Next is case 11, a 38-year-old male with a parroted lesion on FNAC. It had been reported as a pleomorphic adenoma. With elsewhere, the slide was submitted to us for review and it was called a pleomorphic adenoma. The patient underwent a superficial parotidectomy with excision of the overlying skin. And this is the specimen we received. This is a parotid, and you can see a fairly circumscribed nodule which is separate from the parotid. Here you can see this is the overlying skin with a few hair follicles, and this lesion is centered in subcutaneous tissue. It is well circumscribed fibrous pseudocapsule, and on higher magnification you see fascicles of spindle-shaped cells. These spindle cells myxoid stroma, and there are a number of inflammatory cells interspersed between these spindle cells, along with evidence of extravasation of red blood cells at places as seen here. On high magnification, there are few stellate-shaped cells which have large vesicular nuclei with prominent nucleoli. These resemble ganglion cells, and it has a tissue culture-like appearance. Immunohistochemically, the spindle-shaped cells were positive for smooth muscle actin. Smooth muscle myosin heavy chain was negative, consistent with the fibroblastic myofibroblastic phenotype, and this is ALK, which was performed keeping in mind the spindle cell proliferation with interspersed inflammatory cells, and the diagnosis of inflammatory myofibroblastic tumor would enter as a possibility. However, that's not usually so circumscribed. But anyway, ALK was performed and it was negative. So the diagnosis was of nodular fasciitis, and we went back and looked at the aspirate, and this is what we saw. So you have cohesive fragments as well as dispersed tumor cells in a metachromatically staining background. These fragments have the classical troll hair appearance of pleomorphic adenoma, which is described, and here you can see the same. Interestingly, some of these fragments have these long capillaries which are traversing through them, which is not really frequent in pleomorphic adenoma. The cells are spindle-shaped to polygonal, and there is considerable anisonucleosis in the tumor cells. And here you can see some of the nuclei ovoid, while the others are round in shape. And on high magnification, there are a lot of these triangular epithelioid appearing cells with abundant cytoplasm, which have ill-defined cytoplasmic borders, binucleation, and these features are consistent with the diagnosis that was made on histology. The nodular fasciitis has been described in the salivary glands, in the parroted much more frequently as compared to submandibular gland, and it's histologically and immunohistochemically identical to conventional subcutaneous cases. However, it may not always be associated with trauma. This tumor was not located within the parroted, but in the subcutaneous tissue adjacent to the parroted. Histopathologically, you see a circumscribed unencapsulated nodule with a fibroblastic proliferation with a tissue culture-like growth, which is devoid of cellular atypia. Mitotic activity may be increased, and however, atypical mitosis are not seen, and this can lead to misdiagnosis sometimes as a sarcoma. Misdiagnosis is also possible on cytology as seen in the present case. This is a report where nodular fasciitis of the external ear was masquerading as a pleomorphic adenoma, and they have a very nice table which helps to distinguish between the two lesions. Both display high cellularity, and the arrangement is of dissociated cells and clusters of cells. However, nodular fasciitis shows fascicles of cells and a storiform pattern, which is usually not seen in pleomorphic adenoma. While both can show plasmacytoid and spindle-shaped cells, ductal epithelial cells are present in pleomorphic adenoma, whereas nodular fasciitis shows the presence of triangular polyhedral cells with large nuclei. The cytoplasmic borders of the cells in pleomorphic adenoma are well demarcated, whereas those in nodular fasciitis are fuzzy. Pleomorphism is usually marked in nodular fasciitis, while it is minimal in pleomorphic adenoma unless there is malignant transformation. Binucleation and multinucleation are frequent, as are large prominent nucleoli. Mitosis are frequent in nodular fasciitis, but atypical mitosis are not seen. The background can be mucomyxomatous and fibrillary in pleomorphic adenoma and may show chondroid and osseous metaplasia, which are usually not seen in nodular fasciitis. Inflammatory cells are not frequently present in pleomorphic adenoma, while they are variably present in nodular fasciitis. Case 12 is that of a 5-year-old child with a parotid swelling. He had undergone parotidectomy elsewhere in February 2020 with a diagnosis of rhabdomyosarcoma, and he presented to us in October 2020 with a large fungating mass and facial nerve palsy. A biopsy was done, and the FNAC from the initial presentation and the parotidectomy sections were submitted to us for review. And this is the aspirate. You can see that it's highly cellular with a discohesive population of cells, and there's considerable anisonucleosis, frequent mitosis in every field, and on higher magnification you can see that the cells have abundant cytoplasm, and these characteristic cells with horseshoe-shaped nuclei, reniform nuclei, are very evident in this, making the diagnosis quite evident. Here you can see a donut-shaped nucleus, and these features are suggestive of anaplastic large cell lymphoma. This is the sections that were submitted from the parotidectomy, and you can see a diffuse sheet-like infiltrate of tumor cells with considerable nuclear tumor, and on high magnification you can appreciate similar cells as we saw in the aspirate. On immunohistochemistry, LCA was positive, CD3 and CD20 were negative, ALK, CD30 and EMA were positive, confirming the diagnosis. Primary salivary gland non-Hodgkin lymphomas constitute about 1.7 to 6% of salivary gland neoplasms in literature, and they account for 6 to 26% of all extranodal lymphomas in the head and neck region. Extranodal mantle zone lymphoma is the most common primary salivary gland lymphoma, followed by DLBCL, and the former is frequently associated with Sjogren's syndrome, and usually IHC or flow cytometry is required to make the diagnosis. However, ALCL has typical morphology and can be diagnosed without these in a proportion of cases. Parroted ALCL is limited to case reports only, and it is usually extranodal disease. It is seen in young patients. The cells are large with pleomorphic nuclei, which may be horseshoe-shaped, donut-shaped, multinucleated, and with one or more prominent nucleoli. The cells have abundant cytoplasm, which may be vacuolated. Lymphoglandular bodies are few, cell clustering may be evident. And on immunohistochemistry, they are positive for CD30, ALK, EMA, and a T cell marker may be positive or may not be positive. Perforin may be positive, and they are variably positive for CD45. So to conclude, metastasis to the parotid can occur from a wide range of primary tumors. On FNAC, they can show varied cytological features which mimic primary salivary gland neoplasms, and they should always be included in the differential diagnosis of parotid tumors, even if the primary elsewhere is not known, when the histological or cytological features are not characteristic of a primary salivary gland tumor. Ancillary testing should be done in any case where the morphology does not very closely match that of a primary salivary gland tumor, or for cases wherever there is a history of non-salivary gland primary malignancy. And ultimately, correlation with information retrieved from history, clinical examination, and imaging is critical. You saw that many a time we have to call back the patients because the history is not provided to us, and you get the information from the patient themselves. Everything that isn't a primary salivary gland carcinoma is not a metastasis. Everything that looks unusual isn't a metastasis. So we should always keep rare non-epithelial neoplasms in mind, including mesenchymal and hematolymphoid tumors. And lastly, when we're talking about salivary glands, I have to say that pleomorphic adenoma is the most treacherous diagnosis, and a number of epithelial and non-epithelial tumors can mimic it. So we should always make this diagnosis with caution and be absolutely sure, particularly on FNAC, that you're seeing all the classical features before we call something pleomorphic adenoma. Thank you.
Thank you so much. Life has become more difficult. There is a question by Dan Brown on the chat box. What are the differentials of adenocistic carcinoma?
Okay, so adenocistic carcinoma, when it has the classical cribriform and tubular appearance, you would not think of other differential diagnosis, but when it has a solid appearance predominantly, then that is when differential diagnosis would come into your head. you want to think of basal cell adenocarcinoma, which can show similar architecture, but the cells have more cytoplasm. They show peripheral palisading. On immunohistochemistry, the only way to distinguish between these two tumors would be to use MIB immunohistochemistry, because both of them have a luminal abluminal biphasic phenotype and show positivity for the same marker. So MIB IHC would help you to differentiate between them, and also the translocation by FISH or real-time PCR, where you identify a rearrangement of the MYB or MYBL1 gene. Other differential diagnoses which you should always keep in mind when you have a solid looking basaloid tumor are the nut carcinoma. You look for keratinization which is abrupt, and that would help you. And a nut IHC would help you to make that diagnosis. And then third thing, as I showed, is adenantinoma, like Ewing sarcoma, which you should always keep in the differential diagnosis. Again, that shows evidence of epithelial differentiation and squamous differentiation in the form of keratin pearls, intercellular bridges, and keratinized cells. So these are the differentials that you should keep for a solid adenoid cystic carcinoma.
Right. Yeah, basically after your lecture, one thing is very sure, that the confidence of diagnosing anything on FNA is definitely going down. We have to be very careful about all these features, and these are very, very subtle changes, which on retrospectively can be picked up on FNA, but prospectively, with so many variations of pleomorphic adenoma described earlier, you tend to put them into that category of pleomorphic adenoma or acynexal carcinoma, or the simpler ones which we all are well aware of.
Exactly.
I can't hear you. Yeah, hello.
Okay, you were breaking up for a bit, but yeah, you're absolutely right. So, pleomorphic adenoma can show so many morphological variations, and because of the metaplastic changes that you can get, and which is why it can mimic almost anything, and anything can mimic a pleomorphic adenoma if it shows the presence of metachromatically staining matrix. So that is always a diagnosis on FNAC, which looks like it might be really simple, but when you correlate with histology, you'll find out that maybe you're not always right when you make the diagnosis of pleomorphic adenoma.
Correct.
Apart
No,
from that, there are a lot of...
Please go ahead. Sorry.
Yes. Yeah, so I was saying that apart from that, the new entities that are being described, the cytological features are not very well documented. So that is why on FNAC it might be difficult to identify them. And then you go ahead and you use the Milan system and you call it a basaloid neoplasm or a cellular oncocyte or neoplasm, and give the possibilities, a list of possibilities that you would consider, so that the clinician would know how to manage the patient.
Correct. Yeah, but the fact of the matter is that compared to the thyroid Bethesda, the Milan is yet to percolate deep down. Yeah,
That's true. That's true.
yeah. There are a lot of comments which is on the chat box which I have posted. You can see them. Dr. Kanveet Kaur, excellent collection of cases. Sakshi Singhal, very nicely explained. Deepika Mishra, very interesting and brainstorming cases. Thank you for making them so simple. Dan Brown, after your reply, thank you, ma'am.
Thank you so much.
Indeed, a wonderful presentation and very nicely selected cases and very nicely put up in a very, very smooth manner. But at the end of the day, life is becoming difficult even in the salivary gland. Thank you so much, Dr. Aanchal. Wonderfully done. Thank you so much for taking out time, coming here twice and presenting such a wonderful set of cases, teaching us so many things. Please share your PDF. And I will request you maybe sometime in June, July to come back again with something more special.
Definitely.
You can definitely write to me, or I'll write to you and you can reply back as to what we can expect from you sometime in June and July, right? Because I know life is tough. We have so much of work to do. So we'll have some time for you to prepare it out or to think it over. Thank you so much, Dr. Aanchal. Thank you so much. Take care. God bless you. Bye-bye. Thank you. Bye.